To move on with today's webinar, I would like to hand over to my colleague, Nisha Shah, to introduce today's speaker. Nisha.
Thank you, Michael. Yes, we are very delighted to have distinguished Professor Beverley Yamamoto today to give her talk titled Scaffolding, Stakeholder Involvement and Engagement in the Governance of Technologies for Healthcare, and they will be perspectives from Japan. So very interesting talk today. Professor Yamamoto joins us from Osaka University, where she has a number of key roles in global health and education, foremost as UNESCO Chair and as Professor in Critical Studies in Education for Transformation. As a social scientist, Professor Yamamoto's research focuses on a wide range of health and care disciplines, including leading a Pan-Asian project on sexuality education and health promotion, as well as a joint study with UCL on children with complex needs during the COVID-19 pandemic. Professor Yamamoto also leads the Osaka arm of the AIDS project, which is a joint project with Helix, and will be covered in her talk today. Her current research reflects issues in healthcare governance and stakeholder participation. And Prof. Yamamoto is also actively involved in patient advocacy on rare diseases. So she's president of the Hereditary Angioedema Patient Association and a board director of the non-profit organization Discovery Consortium in Japan. So without further ado, I would like to now welcome Professor Yamamoto to begin her talk. Thank you.
Well, thank you very much for that introduction, Nisha. And I'm very delighted to be here today, and thank you all for inviting me, and particularly to share the project that we have been working on, particularly Nisha and other members here today have been working on as a collaborative project between Osaka University and the University of Oxford. So I want to share some of the insights that we have, but focusing more on the situation in Japan and what some of this project means, or some of the implications of our project beyond, within the idea of patient involvement, citizenship involvement in these new technologies. So looking specifically at Japan. So I will put my slides up now, and let's hope that all goes smoothly. Just see. Do you see the slides now? And do they move? No, they don't. Let me just try that again. Oh yeah. Okay, so is that, everyone can see okay there, the slides? Brilliant. I'm just going to move that. So. Okay, so I chose the title Scaffolding Stakeholder Involvement Engagement, because I think that when you want to do something like stakeholder involvement and engagement, there needs to be infrastructure. There needs to be things in place to make it happen, or it's easier if there are things in place to make it happen. Therefore, I want us to think a little bit about what those things might be, and focusing particularly on the work that we've been doing around AI technologies in healthcare. So AI in healthcare in the Japanese context, what does that actually mean? First, we have to think about what is the health system, because obviously different countries, UK, I'm UK born, the NHS system is a particular health system. The Japanese health system is not so far away from it in some ways, because it has a universal healthcare coverage. There's different insurances, but you basically can split them into two: social insurance that's linked to your workplace, or national insurance that is provided by the state. But it doesn't matter which insurance system you pay into, the service you get is identical. And it's a very equitable system, and it's many people think that the longevity that we have in Japan is partly, in large part, due to the system. One aspect that it differs very much from the NHS is that citizens themselves have choice of access at primary and specialist secondary healthcare level, and there's a variety of players in the field, public and private. Physicians have a high degree of freedom to decide procedures, tests, medications, etc. And there's a wide variety of services including things like acupuncture and etc. that are covered under the health service. It has a payment fee schedule system that is set by the state. So it doesn't matter whether you go to a private hospital, public, you know, the fees have been set for procedures, drugs, devices, etc. And all providers have to maintain that schedule. The positive side of that is cost containment, and there's not much incentive to treat one patient differently from another. And it's seen up until now to help those on low income and elderly through medical cost subsidies. We have to pay a 30% out-of-pocket payment for medications and procedures. But if you're on a low income or you're elderly, you get some help. And there is also public reimbursement for those with certain rare and chronic disease conditions. So these are all the things that people usually point out are absolutely amazing about the Japanese health system. But there are real issues about its sustainability and the efficiency of the current system. And it's these issues that really have focused our attention on emerging technologies, and particularly with AI. Japan's had a stagnant economy for at least since the early 1990s, and it has one of the fastest aging populations in the world, which means that the current system's sustainability is really up for question. And without some change, many predict that it will collapse. And particularly because of the heavy burden of medical care for over 75s, which accounts for roughly half of the costs. And Japan has a very large over 75 population. It has consultation fees that are very low, so it doesn't cost a lot to see a physician. But one of the problems with that is it encourages high traffic between the physicians and the patients, and often patients will come for fairly small things, and that is indicated by the physicians to do. So this again overloads the system. Okay, and there's also seen to be, because of the high regulation of the system, a device and drug gap between Japan and other high-income countries. And medical device pricing is regarded as very high compared to other countries, which is a disincentive for certain innovation. And also with the system, because consultation fees are very low and do not allow for much profit, particularly in private institutions, there is an incentive to overprescribe medications, as there's usually drug prices lower than the reimbursement price. So that is a place where the medical system can make profits. So this is just background, because this background forms why in Japan there is a lot of expectation of AI to try and actually help make a system that until now has worked extremely well, but is not seen as sustainable in it, given the current population pressures and the stagnant nature of the economy, and the fact that expectations grow. There's very little gatekeeping done. If you go to a hospital, whether it's a specialist hospital or a primary care clinic, for example, you will be seen that day. So there's very little. So this creates a system that is easy to use, but it's also, there's a lot of worries about sustainability. And some of the emerging issues in the field, as you know, we've got this system in place that up until now has worked very, very well, but we're increasing volume of data that has to be looked at, and this is common everywhere. The administrative burden on HCPs is seen to have grown and grown. And so particularly physicians often feel they have less time with patients now, and they're staying later and later to get the administrative tasks done. There's increased burden around diagnostic imaging and pathological diagnosis, and increasing use of medical devices that now has not yet been regulated in any form. And while there's the expectation that this data could be used in productive ways, efficient ways for personalized medicine, nothing yet has been done to regulate it in the Japanese context. And the other thing for Japan, which is a disaster-prone country with regular earth, in fact, there was a very big earthquake today, and I haven't checked what's happened with that. But disaster preparedness is seen as a huge medical issue, and particularly with such an aging population. So there are also expectations that this new technology, the AI, can help address some of these issues. And as a result of the expectations, it's not surprising that the AI market itself in Japan is expanding and is predicted to expand, as these figures show by Ishii et al. In 2020. It's expected that it will grow to an 87 trillion yen market. And there's expectations of the sort of 3D evolution in terms of healthcare technologies. First of all, digitalization, and then increasing democratization. Japan is seen still to be a rather paternalistic system where the doctors are gods and patients don't question them. I think that is changing a lot, but the greater involvement of patients in the decision-making process, in the processes actually affect them. And then the deep medicine, using AI for creating more personalized approaches. Okay, so the expectation of how AI will be used, and in practice where it's being developed, how it's being used, is it that would augment, I think the pronunciation is, physicians' practice, HCP practice. And so as this diagram shows, that it will support, but it will not take over the final decision making. That physicians definitely will do that final decision making, possibly other allied HCPs, nurses as well, but in a Japanese system, it's the physicians that are usually making the decisions. So that is the expectation, that how it's developed and implemented will still leave the final decision making with physicians, but that this obviously opens up all sorts of questions about how they make the decisions and the degree to which they understand the AI systems themselves. And this is seen as a crucial point of stakeholder involvement, so that the technologies are developed in a way that those using them have an understanding and are comfortable with what they're using. So Japanese regulatory approaches, we have increasing use of public health data directed to all centralized anonymized repositories. And I know in UK, this is something that's been around for a long time, but in Japan, this is relatively new. And it's made possible by the national My Number system, where data, your personal data, is now centralized in one system. And this is very new to have this. And the next generation medical foundation law. So there are movements and the regulatory structures are being put in place to have centralized repositories of data. So this is a big change for Japan, which, because of its while it has this universal healthcare system, the actual providers are extremely diverse and spread around. So up until now, this kind of centralization of data has not really been possible. So this is a big change. And through that, the creation of legal structures to allow for data sharing. So these are all ongoing, very new areas, and ones that Osaka University Hospital is involved in a central way. And there's also restrictions and limitations, as I just mentioned. There is a consensus that AI systems for diagnosis and treatment support and the decision-making will still lie with human beings. And there's also stringent rules on approval of AI technologies, which means that we have less technologies in Japan compared to South Korea or the US, according to Ishii and Nikkei. And there are plans to ease requirements for regulatory approvals in this year so that technology can advance faster. For example, by removing the need for approval for software updates or shortening of initial product reviews. Japan is fairly renowned in the medical field for having its own systems for regulation and being pretty slow because these procedures are quite arduous. So in terms of AI in medicine for diagnosis and treatment support, this also is predicted to be a very, very big growing area. And the government itself is investing huge amounts of money to develop new technologies and to ensure that Japan is ahead of the curve and not behind it. So a big project, excuse me, is the Cross-Ministerial Strategic Innovation Program, SIP. And one of the projects, one of 12 projects within this SIP set of programs is the AI Hospital project. So the project that we're working on with Helix is linking up with the AI Hospital project, because Osaka University Hospital is one of the AI Hospital project. And so we are able to link with the kind of technologies they're developing, and they're very happy to tie up with us because they're extremely interested in stakeholder involvement in what they're doing. This is, I've got from the website, the English is probably a little bit not quite natural in places, but it's the English explanation about it. So the idea is more advanced medicine, more personalized medicine, and more complicated approaches seen in a positive sense, bringing together different areas. Part of the SIP program is to try and get away from these sort of ministerial silos where you don't get the different ministries working together to pursue something, but to actually get rid of these barriers, and so that you have different areas working together, so medicine, engineering, pharmacology, genomics, etc. And the aim is to modernize the hospital system so that, as I explained at the beginning, the healthcare system is seen to work very well in Japan, but not sustainable, and that without modernizing it, the Japanese population will lose this, what hitherto has been a pretty good system to help the system survive. And so the idea is to modernize it through AI, through Internet of Things, ICT technologies, big medical data, etc. And in a way, you'll find the same language of disruption as a positive thing, revolutionizing the system, disrupting so there's that sort of discourse that has come from the US and UK is definitely evident now in Japan as well. Yeah, I think I've explained the rest of that. And so the one project that focuses on AI and healthcare is the AI Hospital project. There are a number of sub-projects, and the Osaka University Hospital is part of sub-project D, which is about the validation of AI tools, development of new AI tools, and hospital digitalization. I forget exactly how many projects they have, but there are numerous. There are a large number of ongoing AI healthcare projects being developed. And we've been very lucky that members of the AID project, myself included, have been on the AI Hospital Committee and therefore able to attend regular meetings where we see what's happening with these technologies. But up until now, there has not been much about stakeholder involvement, and there's definitely a gap in that area. So because I'm a little bit worried about time, I think I won't spend too much time on this, but the expectations around delivery of advanced healthcare, personalized medicine, and also reducing the very heavy burden on healthcare practitioners and trying to improve the satisfaction of patients with the system. And for example, prevention of medical human errors, which are seen to be more possibly prevalent because of the large, the advancement of the system, the large amount of data that is having to be looked at. and also minimization of waiting time, which in Japanese hospitals, you can go to hospital and be seen the same day, but the waiting times are long. But probably that wouldn't be seen as very long compared to the UK system, where you're talking about months rather than hours. But the most common complaint by patients in Japan is the long wait times. But what they mean by that is the long wait in that day. So this is one view of some of the areas that the Osaka University Hospital AI Hospital project is looking at. Big thing is the data bank project, which is now up and running, and department after department is getting consent from patients for all historical data to be uploaded to the data bank so it can be available for development of AI technologies. Increasing use of AI-based image diagnostic systems, particularly in cancer, dementia, ophthalmology, etc. There's a lot of work being done on AI-based frailty detection. My understanding is previously to decide whether a patient is likely to fall while they're hospitalized would require a battery of tests. But now with this new AI-based frailty detection, it can be done pretty easily and quickly. So these kind of things, there's a lot of work going around natural voice recognition for patient notes to reduce the burden on physicians and nurses, and some work not just in hospitals but also for home or for health promotion. So there's a lot going on. This picture actually is quite an old picture and doesn't fully reflect all the work that's being done. And there is a link there to a video, YouTube video that's in English that is more detailed. And that's the data bank project, which is technically, I'm always told, is not AI. It's not considered AI now, but it would have been a few years ago. But that is, at the heart to get the data that is then needed for development of all these technologies. So, okay, so where does stakeholder involvement engagement come into this? Let me just check how I'm doing time-wise. Okay. I think there has been very little work. There's very little infrastructure here around this, but there is growing recognition of its importance. And Osaka University, myself and some of my colleagues have been pushing the research agenda in this area, and often with the team at Helix as well. So we're good partners on this. I think most people are going to know what we're talking about, a patient and public involvement. And I am running out of time a bit, so I think I'm going to skip over these slides. And the US and UK situation. In Japan, AMED, which was set up in what year was it? Fairly recently, 2005, to try and, it's a government-funded organization to try and bridge the gap between medical research, the basic medical research and applied medical research. So it seeks for projects that actually move, that sort of translational research that goes from basic to applied. But then now the organization has started to push the idea of PPI and its importance, largely using definitions that have come from the UK. And these are, for us, also the starting point. And they've created a handbook on PPI, and there is some movement there, but there's definitely not the infrastructure that there is in the UK. And we found that has slowed us down a bit in the AID project. And definitely there's a strong need to build the scaffolding, I think, to be able to move faster with these projects and to make it, PPI itself sustainable within projects. We've had the RUDI Japan project, which was built on the University of Oxford RUDI project. And we've been working together closely on that. My colleague, Professor Kazuto Kato, leads that, but I'm centrally involved in that project. And it's a project aimed more at creating medical data clinical data through PPI. And then we also have the Commons project, which is a PPI project aimed at creating policy evidence, or evidence that can be used for policy. So now moving on to the AID project itself. I don't know how much any of those here are familiar with the project, but it is a joint project. The AID comes, I think it was Nisha that came up with this acronym wonderfully, and it's ensuring the benefits of AI in healthcare for all, designing a sustainable platform for public and professional stakeholder engagement. So we're into year 3 of the project. It has been hard to move it along at times due to COVID, but we have made, I think, incredible progress under the circumstances. It's jointly funded on the Japan side by JST Ristex, and on the UK side, UKRI ESRC. So we set out to see what will affect the implementation of AI, and how and where is AI being implemented in healthcare in Japan and the UK. What kinds of engagement are needed going forward? What safeguards do stakeholders want to see? So these are basic driving questions. In terms of stakeholders, we thought in terms of the developers, the companies, developers, HCPs and other allied workers in healthcare, patient caregivers, members of the public and policymakers. So we have tried to set up a structure to bring in this kind of involvement and engagement with the AI technologies that are being developed in our respective areas, particularly the Trust Hospitals, University of Oxford Trust Hospitals and Osaka University Hospital. So we've done this in various ways, and we've sort of created various levels of engagement involvement, but the most important is the patient and public involvement panel. And I think on the Oxford side, there might be some members listening in today, hopefully. And we have ours on the Japan side. And then we did a scoping review of the landscape through a literature search and social media Twitter study. We're just moving on to the focus group interviews, and then hopefully bringing about recommendations for platform for sustainable stakeholder involvement. So that's thinking about, how we actually scaffold this involvement. So the project is a complicated project. It's quite high maintenance or a lot of labor involved in it. So we try to engage with patients, members of the public, but also experts in the field to talk to them about the issue of how we should be getting stakeholder involvement and engagement in the development and implementation of these technologies. We have yet to talk to AI developers, but that's part of the next focus group part of the project. We have already talked to largely physician researchers who are part of development teams in both countries, and got a lot of information from them, and also tried to sow the seeds of recognition of the importance of PPI or PPIE. And we're working in both sides on interdisciplinary research teams. I think I'll skip that one. In terms of infrastructure, we have no easy infrastructure here in Japan to try and recruit for our PPIP, and it took us a lot longer than it took the Oxford side because of that. So I think this is one of the things that's fairly urgent, to actually create routes for recruitment, because it does hold back. We used various routes. We put flyers in the hospital. We contacted patient organizations, etc. And it eventually got 11 expressions of interest to be in the project, 11 accepted and 10 active members. Their motivations for getting involved, some of it was because they wanted to know how AI was going to be developed in healthcare. They thought it would help them understand more. And they wanted to be involved. Some were from patient organizations, some were just ordinary citizens who were interested in how healthcare was developing. they wanted to be part of what they see as very big change in healthcare and to have some small role in that. And also they thought it would, a degree of enjoyment. We carried out training sessions of our PPIP, and we got an expert speaker in to talk about social and ethical issues around AI. And we've had some workshops with the PPIP to identify and then cluster expectations and concerns regarding AI in healthcare to get a clearer idea. And we've asked them to review our research materials for the focus group. And some of the ideas and expectations they have here have actually sort of fed into how we've formed our questions around for the focus group part. So initial findings of the different work we've done were the landscaping we've done. It makes clear that AI in healthcare, the uptake is accelerating. Even over the 2 years, we're in the third year, 2 years of the project, we've seen an acceleration of the work that's being done in this area. We found that numerous reports, academic articles, speaking with experts, high level of expectation of patient and stakeholder involvement. Let's think wider than stakeholder involvement. But we didn't actually find, for example, in our scoping review, so much evidence of it, and particularly a lack of evidence around patient citizen involvement. Our PPIP had high expectations of the benefits of AI, but also quite a lot of concerns about risks, with a lot of these centering on disparities that are already there in healthcare and worries that this will amplify these rather than reduce them. And in the Twitter study, we saw a strong presence of promotional content around AI and healthcare, which has its own implications. We did a roundtable session of those who are actually involved in developing the technologies to think about the various issues. And when it came to involving stakeholders, we found, because we involved both the Oxford side and the Osaka side, there was a push for PPIE in the UK context, a very early recognition of its importance in the Osaka, and then expectations of the aid project in actually providing some of the early know-how about how to do this. And there was seen to be a need for educational packages to increase confidence of those who are initiating this kind of stakeholder involvement. I'm not going to go through all the results there. And in terms of, this was what we did on the Osaka side, the 2 workshops to find out what their concerns were, what their expectations. I don't want to present all the data here because we hope to publish probably later, but just some of the top things. There was the expectation of improved hospital administration, which was a positive, an expectation, and around this was mentioned on 14 different, obviously we're coding this, 14 different items linked to this. Concerns about changes to healthcare, that it might change the relationship between healthcare professionals and patients public, and it could take out the emotional, empathetic part of healthcare. But also expectation of improved quality of care. They were worried about limitations and loss of autonomy, both of healthcare practitioners and of patients. And they were worried about technical issues and accountability. And much lower down here was cost of implementation. So we're seeing, I think we're seeing very similar things on the Japanese side as what we're seeing on the Oxford side, but some particular cultural differences as well. So the practice of putting into place the PPIP to work on this project, first because we didn't have any specific routes to recruit, we had to do open recruitment, which was quite slow. We then had to bring the PPIP together with us, the researchers, to kind of create a shared language where everyone was confident to speak about AI in healthcare. Some people had no knowledge of AI in healthcare, and then, you know, so there's periods of training and working together to understand what this actually means. So the training sessions, and then our PPIP, both here and in Oxford, actually worked with us to co-design Work Package 5, which is the focus group with various stakeholders, healthcare professionals, public and patients, but not our PPIP, and developers and others who are involved, maybe regulators. So they actually helped us by giving feedback on the scenarios that we were writing, on the illustrations we were using, and we used the earlier workshop work to help inform the questions that we should be asking. And now at this stage where we're just starting to recruit for Work Package 5, the focus group part of the research, where our PPIP are also helping us to recruit. So we found this an extremely effective, informative way of working in this area. So this is a kind of very deep level of involvement, and others through the focus groups will engage with this project in a less deep way, but still important way. But I think the PPIP is central to the way we've structured this project. So some of the sort of last sort of points to think about, and that have been raised in our discussion, is the entirety of an AI system might be out of view for both users and designers. AI systems are dynamic rather than static, and the inclusion of communities in design does not necessarily resolve the causes of marginalization. And I think all these three areas point to the importance and the need for stakeholder engagement to ensure that systems and the technologies work in the ways that people expect them to work. And just as a final wrap up, we think that including the voices of relevant stakeholders in AI development is recognized. This is shown very clearly in our scoping review and in our landscaping, but much more work has to be done. And we're only finding reports of limited work of engagement of patients and citizens. It's more likely to be engaging physicians or nurses or allied healthcare professionals and not patients. We found that there is an interest in the concept of PPIE for AI in healthcare in Japan. And we found this through the AI hospital projects, not just our one, but at other universities. And we need to focus more research activity on creating the infrastructural support and incentives for engagement, and need for greater transparency and information sharing with different members of the public and patients about what's happening in AI in healthcare. So maybe a lower level of engagement, but a very important level. And PPIE and co-production are possible, beneficial and productive as far as we can see with the work we've done in the Japanese context. So I will finish there. There are my acknowledgements, particularly to the project members and our funders. So thank you very much. And I will close the slides at that point. And I think I'm just on the time frame there.
Great, thank you, Beverley. That was really good. That was really interesting. Okay, I feel like I learned a lot.
Oh, good.
So yeah, I will obviously, if people have questions that they would like to ask, you can either type them in the chat or turn your camera on and raise your hand. I think I just will offer a starting question, which, just thinking through the talk, to what are you, so you said earlier on there's quite a lot of interest around the kind of state mobilization of AI in Japan. There was interest in that context in kind of stakeholder engagement and some of the public kind of engagement issues. Do you find that something that people working at the hospital level and hospital management buy into, or do you find that it's something that they struggle with seeing how it could work at a practical level, because it's not something historically that's really fed into the governance of hospitals anywhere, as far as I know?
I think that, you know, even within, for example, the SIP AI hospital project, there's no projects that include stakeholder engagement in their funding, what they say they're going to work on. So even though people sort of pay lip service to it, the work isn't being done. Our project obviously is separate to this. So I think even at that level, there is an issue. But then when you get to the hospital level, again, I think I've seen two reactions. The first reaction are those who are kind of open to this idea and can see that it will be of value, but have no idea about how to do it. And the second group are those who think that patients come to hospitals because they're patients and they come to be looked after, and we shouldn't be placing on them the burden of being involved in all these activities. So a much more sort of paternalistic way of looking at it. I think there possibly those who sort of sit between the middle, who just cannot imagine how it can be done. And that's why I kind of use this idea of scaffolding or structuring it, that without things in place to lower the hurdle, even those who recognize that it's important won't actually do anything, because the hurdle is seen as too high. There's no imagination about how it can be done. And, you know, probably at the best level, it might be some kind of cursory consultation that goes on. However, with the AI hospital group at Osaka, I have found very positive feedback on that. They think that something that is sustainable, something that goes on over a period of time, like our PPIP, that can be there to engage when they want some sort of engagement about the research, would be extremely valuable. And I think that there's a degree to which they have expectations of our project and a kind of reliance that our project may come up with those goods. Whether we can in just 3 years is, you know, is another thing, you know, that's asking quite a lot. But yeah, I think at the practical level, we're even further away from doing it. And I still think there's a tendency to position patients as in kind of passive, vulnerable position, and a slight lack of imagination about how they could actually contribute.
Okay, thanks. Thank you, Beverley. So I see we have a question from Rob Lawrence. Rob, I don't know if you want to turn your camera on, if you want to ask your question, please go ahead.
Yeah, thanks very much, Beverley. That was a really, really interesting talk.
Thank you.
I'm really impressed how you did it in exactly 20 minutes.
Yeah, I was getting worried.
40 minutes.
Because I tend to go over.
That takes some real skill. I declare an interest that I'm involved in the Oxford side of the aid project as a PPI. 2 comments. One is, as a former software developer, engineering manager, in fact, in the later part of my career, particularly interesting that you involve software developers. Cut a long story short, I think many software developers have got quite high altruistic standards, and there's a risk, of course, if they're left to the way that their managers will drive them to produce a product within a certain time frame to meet certain fixed criteria, that they will be unaware of some of the background. So if you can engage those people, firstly in your current study, but secondly when it comes to developing software, if somehow people that develop the AI applications can have an awareness of what's going on, I think it will be to the benefit of everybody, including motivating software developers, and perhaps help them resist some of the potential for financial pressures to produce a product that wouldn't be quite such good quality, and may indeed not be tested thoroughly, and may not take into account some of the risks involved, such as bias, the classic problem of bias. But that's just a comment, really. But it'd be interesting to know what you think on that. I think rolling it out when rolling it out to developers is going to be quite a challenge. And how do you get through to the companies that are doing it? Third parties very often. But the other comment was in the UK, and I'm saying this not so much from an A perspective, but more as someone that is a public patient lay contributor to some AI research. Quite rightly, increasingly in the UK, NIHR puts emphasis on bias. Bias, obviously in the AI, but also in the PPIE recruitment.
Yeah.
And in the UK, that's often involving people from poor socioeconomic backgrounds who tend not to be represented. It also includes people from ethnic backgrounds who for cultural reasons may be less inclined to get involved, may be suspicious, not only suspicious of the AI, but suspicious in getting involved in the as PPI contributors. And very often there's a connection, a correlation between those minority groups, for want of a better word, and their socioeconomic position. I think that's a continual challenge in the UK. Is that also true in Japan, or is it different? Is there a different problem there?
That's an interesting one, and I think even as we recruited, and to what extent is this not an issue? I mean, because we're doing meetings online, you don't have geographical restrictions, but inevitably, if you look at the geography, where are people living who became part of the PPIP, they're fairly within a fairly wide local area, what we would call the Kansai area. So you've got that. It's also quite difficult in the Japanese context to flag up things like, well, ethnicity is just it doesn't emerge as an issue. I mean, it probably should, but it doesn't. Because Osaka has a lot of minority ethnic communities, populations. It doesn't, but there's also, I think, a real reservation about talking about class or socioeconomic status, etc. And so often what you end up doing is using education as a proxy for that. And saying, okay, we don't want to just have those who are highly educated. So I think that's where it ends up. But I do think it's an issue. I think in the 3 projects that I've been involved in, Aid, Commons and Rudy, we've done reasonably well on getting people with different levels of education. But we don't deliberately do it because it's hard work just getting the numbers you need for the PPIP in the first place. And there is also a real reluctance in Japan to select. And this was something we discussed a lot, a feeling that if someone volunteers to be a part of this project, we shouldn't be turning them down. And I think that is a strong cultural feeling. So that makes it a sort of difficult from that point of view. So if we're going to create that infrastructure, we probably need to think about it more. But at the moment, we don't even have the basics in place to be choosy or to decide how we're going to do it. But I do think we need to be aware of this. And yeah, also, do you go for recruitment of people who are already fairly used to PPI and therefore have quite a high level of confidence or not? I mean, in Japan, it's pretty hard. We have those who've been involved in Commons and Rudy, but we deliberately did not go that direction to recruit for Aid. We wanted a more diverse population because the other 2 projects is focused on rare disease. So we didn't want to limit to rare disease, any disease, but also to have public. So we went wider. But I do think these are issues, and I don't think often when you talk about diversity in Japan, you're talking about gender, and that does not mean transgender. It means getting women involved. So that's where we are. And so ensuring that there's enough female representation is often what the diversity issue is at the moment. Yeah, but I do think it's something that needs attention, and as the idea of doing PPI grows and we get more resources for doing it, and then we have more infrastructure, then I think we might be in the position to address these issues more. Yeah,
that's really interesting. Thanks. It just struck me that I think those problems exist in both UK and Japan, but in different ways. The UK might be able to learn a lot from Japan about how to get more women involved, if that's perceived as something that the UK could do more, and I think it probably could. And the Japanese side perhaps could learn more about how the UK is trying to improve its inclusion of what we would call perhaps minority ethnic groups. But so I think both sides can actually learn quite a lot, even though they're at different stages. But I think it's, for both sides, I suspect it's a challenge. Very interesting point you made about not having not just having what I will call experienced PPIE people. I think that's a really interesting point, and it's one that's troubled me quite a bit, because I've been involved in PPI for what, 5 years or something. In a way, I think you need fresh blood.
Probably need a mix, you know.
Yes, oh, absolutely. Yeah, absolutely.
Yeah. And just one other point, I mean, I think it's interesting because I've sat in on both sets of meetings, as you know, and that in the UK, you know, it's bias is the word, whereas in Japan, the equivalent word is disparity. Kakusa is disparity that's learned. So it's not seen, and one of the disparities that's most talked about is regional. You know, because they're clearly, if you live in a city like Osaka, and particularly if you live in the more wealthy northern part of Osaka, you have access to some of the best teaching hospitals in the country, and possibly in the world. But if you live out in some of these rural areas, you may have to travel for many hours to get to that kind of hospital. And there is not, you don't have the same access, and this is an issue. So rural to urban, and even large cities that are, you know, the metropolitan centers and the provincial outliers. So this is what a lot of the patient public members, our panel and other consultations that comes up, is this idea of disparity. And even disparities around some of the doctors, those working in AI, that they want to address a disparate diagnostic skill, that those with the highest diagnostic skills are probably, not always, but probably in the large hospitals, which are in the big metropolitan areas, and not in the smaller hospitals. And they have the expectations that AI will level up, you know, you won't be a kind of postcode lottery about diagnosis. So disparity is a word that kept coming up all the time on the Japan side, but not bias. So I think that one is interesting.
Yeah, that's very great. Give us a chance to speak. But I think that the problem of rural access is present in the UK as well. Perhaps not as extreme, but I think, I mean, I happen to live in a village 20 miles from Oxford, but I'm a Londoner, and I'm quite aware of just how different the access to help is for people in a rural community. It's a challenge, but it sounds like it's much more so in Japan. But anyway, I mustn't take up all your time.
Well, in Japan, you've got massive depopulation of certain. Right. So you've got the population decline, and you've got imbalanced population, you know, so what you have elderly, nobody in this age range, and a few children, for example. You've got very big, you know, imbalanced population pyramids, that's it, and depopulation of rural areas. So this again is an AI issue, when you've got shortage of people to work in those areas. You know, people are not very attracted to go to those areas. So then how can you use AI and maybe robotics to actually increase the access and digital means? So these are all some of the questions. And the other thing is to get more people back into these areas. And there's government policies around this and local policies as well to try and get people to go back to the more rural areas. But they won't go back if the healthcare is not good.
Yeah, it's a vicious circle. Yeah, thanks.
Yeah. The internet connection and the healthcare, they're the two things that people always talk about.
Thanks very much.
You're welcome.
Thanks, Beverley. We have a few minutes left. If anyone has a final question, now is your chance to raise your hand or put it in the chat. Nisha, yeah, by all means, go for it.
I might just pitch in, but really, thank you so much, Beverley. I think absolutely fascinating, and I know we work on the same project together, but there's always that new angle that you always mention that is so interesting. Actually, a lot of the questions have already that I have already been relayed, but I guess if I were to sort of press you a little bit more on sort of the infrastructure side of things, I might be putting you on the spot and you can say no to this, but and I know it's a really complex issue, and certainly in Japan things are still being developed, certainly in the UK, we're really still developing a lot of the PPI side of things and stakeholder involvement with digital and AI technologies. But maybe if I ask you, what would you say should happen in Japan in the immediate future that maybe just a couple of things that you think are key that should happen to improve the stakeholder engagement involvement that happens with AI technologies?
I think the first thing is funding. That with the funding, even if it's just, let's say we've got 10 projects, 10 funded projects are going to be funded on AI in healthcare. In fact, there's many more than that, but let's just say there's 10, that at least one is required to have stakeholder involvement in it, or that you get extra points for that or something. We've got to create the research incentives to do this, and they're not there in place at the moment. I think we also maybe need, and we've commented on this for the Commons project as well, some sort of funding for pilot work. If you're truly going to get the stakeholder involvement and engagement there, you probably want it even before you've put in the funding application. And I don't think even in the UK you have that, so that you could actually do some basic work before you put in the funding application. So there's some sort of pot of gold for that, I think would be really helpful. I also think that we need to get some of the academic associations to have panels or round tables or small sessions within a bigger academic meeting where research that's going on in this area can be showcased. So we need to make whatever is going on more visible. I think the UK has gone a long way to making it a kind of given that there will be some sort of involvement. Maybe I'm being over optimistic there, but I get that impression. But in Japan, it's still seen as something that, this recognition that it's important, but we have no idea how to do it. So, we need more going on. The medical academic associations are really important. They play an important role. So to try to get some sessions in these where we report on these. And then the structures, the recruitment one is difficult, I think, because if you do have a center, let's say AMED decides that it's going to, have a kind of banking system where anybody who wants to be involved in these projects can register. But that's great, but those who register are going to be a particular demographic. So we can't just rely on that. So we need to find other means as well. And I think that the recruitment thing does take so long. And generally, we all only have 3-year funding projects. We rarely get more than 3 years. So I think there needs to be some awareness of that part, you know, of the project, and that, let's say we say, you know, that we're going to take a bit more time to recruit, and that is seen as okay within that. The people who are going to screen funding applications are going to have some awareness of what that means and its importance. So it's raising the visibility of the activities that are going on, but also to raise awareness about the importance of expanding it, I think. And that's part of, you know, the infrastructure around it.
Fantastic. Thank you very much. Yeah, Michael.
Thanks, Beverley. So I think if you've got time for one more short question, I think
no problem.
Carmela has a question. Carmela, are you happy to turn on your camera and ask your question?
I don't know whether I called myself freshly, but anyways, camera's on. So you mentioned at the beginning that doctors in Japan are sort of free to decide what to do with the patient. And that reminded me on something, and that leads to the question. In 70s, when I'm now in Canada, and I was still in then Yugoslavia, we were invited at the School of Public Health to develop some continuing education, easy stuff for doctors, primary healthcare doctors in Japan, because they were considered by their ministry or the healthcare system that they do not evolve. Once they get a license, they just don't follow what's going on. So we developed a series, that was 70s, so 80s, sorry. So we developed a series of little games in computer, how you get a patient, give the tests, and then whatever happens. And even little movies. I remember always the film we made with the apple, you cut apple in half, you say half of people with high blood pressure don't know, then you cut it again, and you say the other half that does know doesn't take medication, blah, blah. So this leads me to, if it's still a little bit of independence, quote unquote, whatever that means, of doctors to do or not to follow the new stuff. Have you, what would be the acceptance by doctors of AI, of artificial intelligence? And if it's difficult, because you mentioned training and this, not just of patients, but also of health professionals. And I'm now also linked to the medicine, Professor Radman in Split. Have you considered to start with future generations to educate them in the undergraduate stage, future doctors, about that? Because my grandchildren know more than I do. Sometimes they get stuck on whatever, computer stuff. The undergraduate, that would be maybe easier to push through, to overcome whatever. Have you considered that to reach the future generation of physicians? So there's the shortest I could get on before they start yelling at me.
I haven't heard anybody talking about this yet, but I'm sure it will go on the agenda. And I think, you know, innovations in the training of HCPs, you know, the basic level undergraduate. In Japan, for a physician, you do the 5 years. I think it's 5 years. It's undergraduate. I think it's the same as England.
Usually it's 5 years, yeah.
So you do your undergraduate training and go on. But I think there are already people saying it's not keeping up with the changes and the demands that are on physicians once they're out there. And primary healthcare here is so diverse. The landscape is extremely diverse. And you have a lot of private clinics that sometimes they're handed down through a family, you know, father to son often, maybe father to daughter. And yeah, they have incredible autonomy really to do what they want to do. And so a high level of discretion can be good, but it can also mean that you have very big differences in how the same disease condition or the same set of problems is actually dealt with. But that's beyond my area of expertise. I don't know that much about, how doctors are trained. But at the moment, I think most of the focus is on how those who are already trained and those who are going to be working in the advanced medical care system, not the primary health care, are going to be using AI. But Japan uses technology at every level. I mean, so I can see that it will go down, that it could go down. But at the moment, the focus is on the big advanced healthcare level for AI. And, I think you will start to get the undergraduates trained as well. I'm doing a lecture on undergraduates in a couple of weeks. Maybe I'll go and ask them if they're receiving any training at all on AI.
Okay, yeah, thank you. Yeah, I didn't mean only for primary care, even for hospital care, even more difficult. The experience I had, I don't want to say which country, but the specialist in hospital would say, when you come with whatever your primary physician or other, who told you to do that? So, so this is, and then we had another webinar organized by Helix, or one up a day, whatever. So interestingly was that people were more willing to share what they picked up by self-diagnosing with friends than with the doctor. So there is another barrier there that I see will be interesting to overcome. Will the doctors accept, because you said some sort of artificial intelligence helping you to discover what it is. And it's been discussion here in Canada because people tend to go straight to emergency with whatever. So let's hope this will be overcome with those, that you can do something on the internet, but there is always a danger you'll do something wrong, or the danger you won't do it, whatever. So it's interesting how this artificial stuff is getting into our lives.
Yeah.
What will that change, hopefully in a positive term, but it should be mutually acceptable to everybody, and it should be at the level that can be accepted and can be trusted, better to say than accepted, can be trusted on all the levels. So anyways, okay, so good luck.
There's been quite a lot of work going on here through JST RISTEX on this trust issue, bringing together various disciplinary background researchers to think about this trust issue. Obviously, I approach it from the stakeholder.
Yeah.
But I think, again, the trust thing is seen as critical. And okay, how do you develop this trust? And I don't think you can do it without engaging stakeholders.
Oh yeah, definitely. I mean, trust of stakeholders, but stakeholders also doctors, right? All of them.
Of course they are. Of course they are.
Whatever level. Yeah. Okay, good. Thank you.
Thank you very much.
Okay, thanks everyone. I think we will have to call time on that, but there's been some really good questions, and thanks again, Beverley, for coming along, giving this talk, and for answering everyone's questions. And yeah, it's been a really good contribution to our webinar series. So thank you.
Thank you. It's my pleasure. Very, very interesting.
Thank you so much, Beverley.
Okay, thank you.
If I could ask you to stay for one moment, Beverley.
Okay.
And